So we're going to start with our scenario. We've done an assessment on our patient. We've made a determination that they need an IV in order for us to administer fluid resuscitation for them for dehydration. So we're going to start scene safety BSI. We're in our BSI here. Introduce myself to the patient. So, Mrs. Jones, we'd like to start an IV on you today in order to be able to give you some fluid. Is it okay if I start an IV on you? Yes, it is. Great. All right. Is there one arm that's better than the other? This arm's fine. Okay, perfect. All right. So I'm going to have you just relax for a moment. I'm going to pull my equipment together, and I'll let you know everything before it happens. So at this time, we're going to start assembling our equipment. So I'm going to check my fluids. This would be taken out of package. It would be aseptic. And this is where I'm checking and making sure 0.9% sodium chloride is within our expiration. I'm checking, making sure there's no particulars, there's nothing floating in it, it's a full bag, it hasn't been tampered with. And at this time here, we're going to open our extension set. And like we talked about, we're going to use our MAC drip. So we're going to use our 10 drop set. Again, this would be coming out of packaging. So we're going to make sure that there's no kinks in it as we open it up. So as we do this here, we're going to come in. We're going to remove the cap that comes with the bag. We're now going to spike our bag. And this is where now we can hang this up. We're going to fill our drip chamber about halfway full. All right, and this is where now we're going to drain this, and we're going to flush all of the air out of this line so that there are no air bubbles. So we'll open this up. And we're going to let this run so we can see, as we start to watch, our fluids coming out through our chamber. This is going right into our basin. And you see all of our air bubbles making their way out. Once we've determined there's no air in our line, we'll shut it down. All right, and now this end here is still capped. All right, we don't reuse things in the field, we do sometimes in lab. So this is capped, and I'm going to attach it right here. This will keep it up. The nice thing about attaching it into this little flow chamber is that as I do that, if I'm sitting down or standing up, I can adjust this so it's right at the height I need when I want to go to attach it to my patient. So now that I've got my fluid set, my line is flushed, this is ready to attach once we have our angiocath in place. I've got my equipment out. And so this is where now I want to come in, and with our tape we can have a couple pieces. A lot of times in the field you may just use your TEGADERM. All right, so this is really a bio-occlusive. So we can take this out. Now the bio-occlusive, they come different. You may have a TEGADERM, you may have a veiny guard. So the bio-occlusive is just the kind of brand name here. So this here is our backing. So if you've never seen these before, this comes off. This part opens up. This part here. And so now when this seals on, you can see that there's writing on this side of it. So anytime we have writing, we know that once we attach this to our patient, so the adhesive side goes down, and now what happens is we're able to peel this backing off. Okay, so that just gets thrown away. So anytime you have a grid, if you have writing on that, that thing comes off. On this end here, you've got your two little adhesive pieces, so you can use this to secure over if you don't have tape. You can also write on that for time and date. So all of those things kind of come into play. Okay, so again, we've kind of come in, we've taken a look at our equipment. So you have the ability to kind of cut a couple pieces of tape. You want to still be talking to your patient, how you doing, how you feeling, any concerns. You know, this is where now we would be continuing with our assessment, you know, as needed. So you cut a couple pieces of tape, and again, this is not aseptic, so this is where now we'll use this to secure the line, but we're not using this in any manner to put over our veiny puncture over the site. So now we want to come back to our patient. We want to let them know, okay, so we're going to put this band around your arm. It's going to get a little tight. So this is where there's lots of different ways to secure this. It doesn't really matter as long as you meet the objective. So by being able to cinch this nice and tight, the way that this is here, I'm able to release it with just one pull. Some people like to come in and kind of fully tie it over, but you want to get this nice and tight, cinched, kind of tuck it under, pull this. So now the purpose of this again is to help kind of engorge these veins. So now as we start to palpate, we can find a good vein that we want to come in and take our attempt. We generally like to go more distal than proximal because if we are unsuccessful, we can move further up the arm. If we start at the AC and we kind of blow that, we've kind of lost this arm. So now when we come in with our alcohol prep pad, once we've palpated and we found where we want to go, we want to come in, we open up our alcohol prep pad, and now we want to cleanse in what we call outward concentric circles. So I don't want to go back and forth because that's just going to take the bacteria and just run it back over the site that we're going to go to. So you do this outward concentric circles and then that gets thrown away. So we don't reuse the alcohol prep pad. You open a new one if we need it. We want to let the alcohol dry on its own, so you don't want to blow on it or rub your hand over it. That's just going to introduce more bacteria. So you let that kind of dry, and as you're doing that, you're going to pull out your catheter. Now, these are a lot different than what most people use in the field, but we also know as EMS with the redheaded stepchildren. So when it gets to the point where they're going to pull supplies and we're going to get the cheap stuff, it's going to be on us. So these are your non-safety, non-self-occluding catheters. You want to make sure when you spin it that the hub here, this spins, is free spinning. There's no burrs. There's no, sometimes here because it's plastic, can get imperfections. So if I had any issues where this wasn't free spinning, if I had pulled this up, so if this comes up where now I have the catheter above the needle, you never thread it back through. That will give you what we call a catheter shear. So you would throw that away and you would get a new one and we would start over, right? So we would pull this out, and this is where now we want to make sure catheter isn't over, everything is free spinning, and we want the bevel end up. So you want that facing up from your patient. So now once we've come in, we never repalpate where we've already cleansed because that would reintroduce infection. So we're going to come, we're going to pull some distal traction. That's going to, the distal traction is going to make the skin taut. It's going to help us be able to see the vein a little bit better. And then it's also going to give some stability to the vein in case they roll. So now as we come in, we've got our bevel up. You're going to come in 15, 30 degree angle, and you're going in just until you feel that veiny puncture. Now we start to get our blood in our chamber. And now what we're doing is we're coming in and we're advancing this catheter until we get flush here. I'm going to occlude. We're going to pull this out. And this is where now the occlusion is going to stop our blood flow. It's also going to prevent air from coming into this catheter. I'm going to take my lure from my extension set. I'm going to then pull back. So now at this point, I want to undo my tourniquet. I'm going to open up our line. And we want to make sure that we have a good patent flowing line. So we want to make sure that we see this going into the patient. There's no signs of infiltration. It's not bubbling under the skin. There's no pain. There's no burning. For just purposes while we're talking, we'll shut this line down. So this is where now we've got this in place. I don't want to let go of this until I have it secured. So here you can either come in and take one of your pieces of tape. You come back on the tubing. And now we're able to kind of build this up to help keep this in line. Now we come in and we take our TEGADERM, VeiniGuard, bio-occlusive, and now this is where we'll take the sterile backing off, and now we're going to come in, we're going to place this over the insertion site. So we'll now secure everything. Alright, and then make sure that this is now nice, secure to the patient. I'm not covering the hub. If I had an extension set, then I could come in and kind of shellac this, but if this is all I have available, I want to leave this out in case I need to change out this tubing. If it gets kinked, something precipitates in it, I want to have access to that. So just like we talked about, we now have our adhesive on, our backing comes off, and now this allows us to have a good clear vision of the insertion site. So now this is sterile, we're protecting that, and that's the purpose of the bio-occlusive, is to protect where we just made this insertion directly into the patient's blood supply, right? So the circulatory system, blood at rest, on average, comes in contact with every cell about 3 times in 1 minute. So if we introduce infection to this patient, it's not uncommon for them to develop a phlebitis, a cellulitis, they become septic. Some of the things we do as nurses, paramedics, we come in and we have an opportunity to kill the patient immediately. We give them the wrong med, we can do something terrible right away. Something like this here, if we're not using a aseptic technique, we may not kill them immediately, but now all of a sudden they end up with a significant infection. That's going to decrease their output for leaving the hospital, so their quality of life, and then potential it could kill them. So we always want to make sure we're using good aseptic technique. Now we can come up here, and this is where you can do whatever you want. Some people like to do a fancy chevron, some people just like to get it up out of the way, and this is where now you come in with another piece of tape. not impeding your view of your window for any signs of infiltration. And now you've got this picked up on the patient. You'll time and date this. All right, so we know what time and where this was placed. So, especially when we get them to the hospital, they know when this needs to be removed. Certainly if there's any problems with it. Here we've got our Lure Connect. We always have our closest port. So this is where, when we look, in our upcoming video of how to deliver medications, we're going to go through this port here. All right, so we always go through the closest port. It's the least amount of the extensions that we've got to get through, and then we'll flush the line. So we said that we were going to give this patient some fluids. Right, they were dehydrated. So this is where now for an adult patient, we'll start with, like, we have 1,000 bag hanging up, but we'll probably start with a 250 milliliter bolus. So we're going to open that up, we're going to let that run into our patient, and we're going to be reassessing our blood pressure, certainly our lung sounds. And again, the length of time it takes for that amount of fluid to get into our patient depends upon the health of the patient, the reason we're giving it to them, the vasculature, the size of the catheter that we gave them. So it could be anywhere from, several, 8, 9, 10 minutes to it could be, 30, 45 minutes. If we have a cardiac patient, someone with renal failure, we've got to be very cautious with this fluid resuscitation. So we can't just open it wide and run it into everybody. You have to make sure that you've done this assessment. And when we're giving fluids, one, that they're indicated, and that we're monitoring the response of our patients. So, fluid resuscitation, normal saline is a medication. In cases where we have cardiac patients, renal patients, we can't have, negative effects from our intervention. So we would want to make sure that we're being cautious and doing our due diligence, reassessing the patient, checking vital signs, clinical improvement. So it may just be, not just about what a blood pressure looks like. We like to say, well, we'll give this to a systolic of 90, but if I have a patient whose blood pressure is over 90, we've already exceeded that. So now we're looking for, are they less tachycardic? Is their skin, condition, are they starting to pink up a little bit? Do they feel less nauseous? One of the major indicators of dehydration is tachycardia. So are there some things now that we're watching and able to monitor on this patient? Are we seeing, is there improvement? Are they less dizzy, less confused? So those would all be good clinical indicators saying that the fluid resuscitation is now helping our patient for things like dehydration or hypovolemia. When we get in some of our other videos, we talk specifically, patients who have sepsis, patients who have burns, our trauma patients, we'll look at, fluid resuscitation, and we may have some other limitations that we need to take into consideration. And there may be other medications that we have to administer to help the fluids that we administer either stay in. So when we look at a patient who's septic, if they're severely septic, well, we may need to look at a pressor making a container in order for it to hold the fluids that we give to it. So, certainly this is, one of the things that we do pretty frequently for our patients starting an IV. Most hospitals, the standard of care that they at least have access in case something happens. So being able to do this with aseptic technique, finding a good location, getting a good patent line, and then making sure that it stays patent and we don't do anything silly like pulling it out, pushing things in that are going to precipitate. And in some cases, we may have to start another line. So all of these things are based upon the assessment that you've done for your patient. What are the indications now for fluid resuscitation? Okay. So hopefully this was helpful in terms of how to get things started. You kind of see how this kind of assessment stations goes. They're looking for the big things here. Don't do anything that's harmful to your patient. So don't touch anything after you've cleansed it. Make sure that you cleanse things before you take your attempt. Don't re-stutter with the needles. So if you go in and you have to come out, get a clean needle and go in. Don't introduce anything with catheter shears, or if you had a damaged needle with burrs. All of your sharps, after they go into a biohazard container. You don't then start a line and then put the needle on the table or the couch or the bench seat. All of those things go in a biohazard container because that's the safety concern not of the patient, but for us and our partner as well. So really the things that get hung up here, safety concerns, and then making sure that we're not introducing any signs of infection. Generally when you're in school, that's your best practices because you have someone standing over you being like, don't do that. So when you get out, you do things, you take shortcuts, things happen. When we're starting lines in the ambulance, it's kind of a giant MRSA mobile, right? So now as we come in, we're looking at what can we do to minimize the likelihood that we're going to introduce infection to this patient. If this were your loved one, what precautions would you take to make sure that they didn't get sick and they didn't get an infection? If you use that as the standard, if you treat everyone as this is the person who's most important to you in your life, what care would you render to them? You will not go wrong when you treat your patients. All right, so this is our IV start. We went over our equipment, so kind of our setup. Here's our IV start. We'll look at it in a little bit. Upcoming video, you'll check out our med administration. So if we're going to do a med push, how do we do that? All right, so hope you found this helpful. Leave a comment if there's videos or other topics that you'd like to see, or if you have questions, happy to get back to you. And we will see you next time. Go ahead and check out our other videos over at Digital Therapy Academy. Take care.